The webinar is opened.
Good afternoon, but also good morning and good evening to many of us. It's our pleasure to welcome you to our third webinar in the series of ITM alumni webinars featuring the ITM winners of the Prize for Global Research 2021. This prize is awarded yearly by the province of Antwerp to research projects of master after master students of ITM and other higher education institutes. Development relevance, quality, and originality of the master thesis are key in the selection. Through this award, the province of Antwerp wants to stimulate research relating to the Global South. In the third webinar, MTM alumnus and laureate Jahan Mallick will present his master's thesis entitled Acquired Beta-Acylin Resistance During the Treatment of Drug-Resistant Tuberculosis, a systematic review. The main aim of this series of alumni webinars is to share research findings, expertise, and experiences on a specific international health topic within the ITM community of alumni, students, staff, partner institutions, and the wider global health community. I will now explain some practicalities of the webinar. If you want to ask a question, you can use the Q&A option you will have below your screen. You can ask a question anonymously if you would choose to do so. The chat is being disabled for questions. Questions will be moderated and only a select number of questions can be answered in live given the limited time. Unanswered questions cannot be answered individually afterwards, for which we apologize. At the end of this webinar, a short survey will be displayed and a browser window will open to give your feedback. The webinar is being recorded and will be made available afterwards on the ITM alumni platform. Our today's moderator is Tom de Croo. Tom is a medical doctor who works as senior researcher at the Department of Clinical Science of the Institute of Tropical Medicine. At present, he is involved in multiple research projects on the diagnosis and treatment of resistant TB. Tom, the floor is yours.
Thank you for the introduction. I will, from my end, introduce Jahan. Jahan Mallick worked as a medical resident in internal medicine at a regional hospital in Germany until he decided to enroll in the Master of Tropical Medicine here at the ITM in Antwerp. Here he focused especially on the issue of drug-resistant tuberculosis, and currently he's working with an NGO in Greece to provide medical care for people with limited access to local healthcare. So Jahan, please go ahead.
Okay, thank you for your introduction. So today I will present my thesis on acquired beta-acylin resistance during the treatment of drug-resistant tuberculosis. I will start with a short overview about TB itself and then present the approach and the findings of the thesis. Tuberculosis is caused by Mycobacterium tuberculosis and is transmitted via aerosols. It causes a granulomatous inflammatory disease, and most infections show no symptoms, but in 5 to 10% of infected people, it can lead to an active TB disease, which typically affects the lungs, but can also affect other parts of the body. Regarding the epidemiology, about a quarter of the world's population is infected with TB. And in the last year, almost 10 million people fell ill with TB disease. Regarding the mortality, until the start of the pandemic, TB was the leading cause of death from a single infectious agent worldwide, even before HIV and AIDS. And last year, about 1.5 million people died because of TB. And you can see there's an increase in the last year, and it's feared that this increase might continue in the upcoming years as well. How to diagnose TB or TB disease? Either clinically, based on symptoms and usually imaging, but better if you confirm it bacteriologically. This is when a specimen tested positive in microscopy, culture, or rapid diagnostic test like GeneXpert. What's very important as well is drug susceptibility testing, because drug-resistant TB is a major public health threat, and it really defines how you treat your patients. You can either do that phenotypically based on a culture, or genotypically, for example, with GeneXpert, line probe assay, or genomic sequencing. Drug-resistant TB. On the left side, you see a map of the people who fell ill with DRTB in the year 2019. You can see that the highest numbers are in India, China, and Russia. Rifampicin-resistant tuberculosis, or multi-drug-resistant tuberculosis, meaning resistance to rifampicin and isoniazid, is estimated in 3.3% of new cases and almost 18% of retreatment cases, leading to an estimated number of almost 500,000 cases per year, of which only less than half are actually notified. Of those notified cases, about 60% are tested for rifampicin resistance, but even less, only half, are tested for resistance to fluoroquinolones. What's also quite disappointing are the treatment success rates, even though they're a bit increasing over the last few years, with almost 60% for RR or MDR-TB, and about a third for XDR-TB, so additional resistance to fluoroquinolones or second-line injectable agents with this definition. The treatment guidelines. Currently, drug-sensitive TB is treated with the 6-month course of the well-known 4 first-line TB drugs. For isoniazid-resistant TB, you add levofloxacin, even though some experts are skeptical about this approach. For rifampicin or multi-drug-resistant TB, you have 3 different options. First, a standardized short all-oral regimen, which is usually given for 9 to 11 months, consisting of an intensive phase and then a continuation phase. But there are certain requirements. For example, that you weren't exposed to these drugs in the past for more than 1 month. You shouldn't be pregnant. You have to be older than 6 years. So quite often you have to use longer individualized regimens. The third possibility is to use regimens under operational research conditions. This means that there are certain requirements you have to follow regarding monitoring and safety. The most well-known one is the BPAL regimen, which is a 6 to 9 month course of betaquilin, pretomanid, and linezolid. So how to construct a longer and individualized regimen? Usually you apply it for 18 to 20 months. The WHO groups the anti-TB drugs in 3 groups and recommends that you should use, if possible, all 3 agents from group A, the fluoroquinolone, betaquilin, and linezolid, and then add at least 1 group B drug like clofazimine, cycloserine, or tericidone. Sometimes that is not possible because of contraindications or because there's proven resistance against these drugs. So you might have to add less effective drugs from group C. In 2016, in the previous guidelines, the options were much more limited. The backbone of the regimen was formed by a fluoroquinolone together with the second-line injectable agent. But the WHO decided to phase them out, to abandon them, because there were concerns about their toxicity, and a large meta-analysis revealed that they may actually lead to worse treatment outcomes. Even though some experts question the validity of this analysis, the WHO decided to go through with it. Just a small reminder about drug activities. As you might know, mycobacteria have a very long generation time of about 20 hours, much longer than other bacteria. For example, E. coli only needs 20 minutes. So they have different metabolic stages. One where they are highly active and multiplying, but also other stages where they are almost dormant with very low metabolic activity. So you need drugs that have an early bactericidal effect to work on those active multiplying bacilli, but also ones with a sterilizing effect to go for the ones with low metabolic activity. And every regimen should have at least one drug that combines both, also called a core drug. And back then, this role was only fulfilled by the fluoroquinolones. And with the rising numbers of fluoroquinolone resistance, this posed a problem. So people were quite optimistic when bedaquiline was introduced, a drug that inhibits the mycobacterial ATP synthase. Its main advantages are that it is a core drug, so has both high bactericidal and sterilizing activity, that it can be given orally, and that it has shown to improve rates of culture conversion and TB-related mortality among DRTB patients. At the end of 2020, more than 100 countries worldwide were reporting its use for their patients. But in recent years, there were more and more reports about acquired bedaquiline resistance, which is defined as the phenotypic or genotypic resistance acquired during treatment among patients with susceptibility at baseline. It's mediated mainly via mutations in the genes RV0678, encoding a transcriptional repressor of an efflux pump, ATPE, encoding a subunit of the ATP synthase, and PEPQ, an aminopeptidase. To illustrate the most frequent mutation, once the RV0678 gene mutates, it leads to a deviated RV0678 protein. This can act no longer as a transcriptional repressor for the MMPL5, MMPS5 gene, which encodes for two proteins who together form an efflux pump. So when this gene is not inhibited anymore, a lot of efflux pumps are built, leading to decreased concentrations of bedaquiline in the mycobacterial cells. Possible factors for acquired bedaquiline resistance, or short ABR, might be the long elimination half-life of bedaquiline, which is 5.5 months, so almost half a year. Then its delayed activity onset. The bactericidal activity only starts about a week later after the first administration, together with the lack of drug susceptibility testing capacities before treatment start, especially for fluoroquinolones, who are expected to protect bedaquiline during this vulnerable period. This can lead to possible treatment failure, failure to protect other drugs, cross-resistance, for example, to clofazimine, and the emergence of complex resistance patterns with very limited treatment options. Sabira Tessin and colleagues examined 3 recent cohort studies and found a frequency of ABR ranging between 2.5 and 30.8%. But to date, there was no comprehensive review that had a look at the available literature to find out where does the actual frequency actually lie. So initially, topic of the thesis. Currently, I'm working with this lovely team on the publication, and we're hoping to succeed until the end of the year. So stay tuned. The research question was based on the PICO approach, asking what is the frequency of ABR during the treatment with beta-kilin of patients with DRTB. The primary objective was exactly that. As secondary objectives, we also wanted to examine trial characteristics, treatment regimens, and outcomes, and additionally to examine individual features of patients who acquired beta-kilin resistance, like their resistance profiles or their treatment regimens. 3 databases were searched, Central, PubMed, and Embase, and studies in English with primary patient data of humans, so no secondary data from literature reviews, for example, with Mycobacterium tuberculosis of patients treated with beta-kilin, which provided sequential beta-kilin drug susceptibility testing data to meet the definition of acquired resistance. If studies solely reported on patients with acquired beta-kilin resistance, like case reports, case series, we did not include them, as the frequency would be 100%. Also, if it wasn't clear how many patients in the parent cohort were treated with beta-kilin, studies were not included because we did not have a denominator and therefore could not calculate the frequency of ABR. Several tools were used, and the quality assessment was done with the Newcastle-Ottawa scale for cohort studies and the WARP2 tool for randomized controlled trials. The frequency of ABR was assessed in 2 categories. First, phenotypic ABR, which was based on the measurements of minimum inhibitory concentrations. To calculate the frequency of phenotypic ABR, we put all patients who met these conditions in the numerator and divided them by all patients treated with beta-kilin in these cohorts, or in that cohort, without those who had phenotypic baseline beta-kilin resistance. For genotypic ABR, we looked at resistance-associated variants or mutations. It was calculated in a similar way by putting those who acquired these mutations in the numerator, dividing them by all patients treated with beta-kilin without those who showed these mutations at baseline. 2 additional measures were calculated, where we only put those patients with phenotypic or genotypic ABR in the numerator who had an adverse outcome, like treatment failure, death, or loss to follow-up, and not those who had a successful outcome, like cured or treatment completed. To come to the results, about 1,300 records were identified and 864 were left after duplicate removal. 588 of them could be excluded by title and abstract screening, and 276 full text were checked for eligibility, eventually leading to the inclusion of 13 studies in total. Study characteristics. On the left side, you can see a map, and in red are the countries where study cohorts were located. Most of them were single center studies, but a few multi-center studies took place as well. The majority were cohort studies, and 2 randomized controlled trials were included. When looking at resistance patterns, because most studies were performed already a few years ago, we used the previous definitions from the last year and not the new definitions published at the beginning of this year. For MDR and XDR-TB, they were present in about 1/3 of patients in these cohorts, and pre-XDR-TB in about 15.3%. Comorbidities like HIV and hepatitis C were present in about 1/3 of the cohorts, and about 2/3 of patients had a history of TB disease. Regarding the regimens and outcomes, the regimens were mostly individualized based on patient characteristics. Only 1 study used a standardized composition, which was the BPAL regimen. Fluoroquinolones and second-line injectable drugs were frequently used. Beta-kilin was usually given for about half a year, and the frequency of favorable outcomes, like cured or treatment completion, was about 50% in the majority of studies, and above 80% in 5 of the 11 studies who provided outcome data. This is quite a full slide, but it shows the main findings of this review. Here you see the 13 studies that were included, and here the cohort sizes that varied between 10 and 277 patients. These two columns show the frequency of baseline beta-caline resistance, so before treatment start. It amounted as a median phenotypically to 2.2% and genotypically to 2.9%. These two columns show the frequency of acquired beta-caline resistance, so our primary objective. Phenotypically, it amounted to 2.2% and genotypically to 4.3%. But you can see there are some outliers, like here and here, and partially incomplete data. The frequency of ABR among those patients with only adverse outcomes was phenotypically 1.1% and genotypically 2.9%. When looking at individual characteristics of patients who acquired beta-caline resistance, for the phenotypic ABR, we had available data on 15 patients. Most of them had advanced resistance patterns. And the number of likely effective drugs, which we define as drugs at treatment start without evidence of resistance, was 5. Then we assessed the protection of beta-caline either by current group A drugs and the most frequent used companion drug in the previous guidelines, the second-line injectable drugs. Linezolid was used in most regimens, whereas fluoroquinolones and injectables were only infrequently used. Outcomes were mainly unfavorable. This was similar for the 21 patients with available data who acquired genotypic ABR. They also had mostly advanced resistance patterns and a number of likely effective drugs of 5. Beta-caline protection was similar, even though linezolid was less often used and injectables more often. Outcomes were again mostly unfavorable. So overall, study characteristics, treatment regimens, and outcomes were heterogeneous, and the data partially incomplete. That is why we refrained from doing a meta-analysis. The ABR frequencies we found were coherent with the model estimation performed by Amber Kunkel and her team a few years ago. The difference we found between the phenotypic and genotypic frequencies of ABR can be explained by the fact that not all resistance-associated variants do actually confer resistance. So it was not surprising for us. Regarding individual characteristics of patients who acquired ABR, the median number of likely effective drugs was consistent with WHO recommendations. They do recommend at least 4 likely effective drugs at treatment start. We also saw mainly unfavorable outcomes. And regarding beta-caline protection, most patients received linezolid, whereas fluoroquinolones and second-line injectable drugs were only infrequently used, thus supporting skepticism about the high and early bactericidal activity of linezolid. So there are some limitations. About the first two we already talked, but there was also, regarding the quality assessment, a medium risk of bias of the included studies. If you're interested, I can elaborate further on this later on. Then there's always reason to assume that there might be a possible over or underestimation of the ABR frequencies, not only because of the heterogeneity of the included studies, but also because only a handful of studies provided an appropriate follow-up time after the end of the beta-caline administration. We define that as 6 months after the end of beta-caline treatment because of the long elimination half-life of 5.5 months. Also, patients lost to follow-up are at particularly high risk for acquiring beta-caline resistance because once they stop taking their medicine, all the other drugs are much faster out of their system than beta-caline, leading to a monotherapy for weeks or even months. But you can imagine it's difficult to assess the frequency among these patients. Also, we did exclude studies who solely reported on ABR, even though they might provide valuable insights on individual patient characteristics. So how to prevent acquired beta-caline resistance? There are some challenges coming with it. So not all resistance-associated variants are discovered yet, and there's so far no comprehensive register that grouped these resistance-associated variants. Even though Camus Nimmo tried to examine a certain number of isolates and look at the mutations he found, he grouped them in resistant, intermediate, and susceptible. It's still a very limited overview. Then there's a discussion about the MIC thresholds, or the critical concentrations above which you would declare resistance regarding phenotypic DST. Because in some studies, it could be shown that even patients with lower MICs can be more likely to have unsuccessful treatment outcomes. And additionally, there's a lack of standardized reporting and surveillance of acquired beta-caline resistance. One of the biggest problems is also the availability of drug susceptibility testing to the key drugs, and especially fluoroquinolones. But even though if fluoroquinolone DSTs are available, there's a problem if patients have mycobacteria with coexisting susceptible and resistant bacteria populations. This can either be heteroresistance, so of a single strain, or mixed infections of more than one strain. The problem is that even our best tests, like the phenotypic DST or next generation sequencing, they need a threshold that above 1% of the mycobacterial population of resistant bacteria. But quite often at treatment start, there might be less fluoroquinolone resistant bacteria, and only over the course of a few weeks or months, they become dominant and increase above that threshold. So even though you might have a susceptible test at baseline, this might not be fully true. Last but not least, the regimen composition can be difficult if in certain settings, not all drugs are available. Some suggestions for preventing ABR. Maybe the most important is the improvement of DST capacities. On the right, you can see a map on countries who tested for fluoroquinolone susceptibility, and you can see wide gaps, especially in sub-Saharan Africa. So this is definitely something that policymakers should consider to improve. Also, as we have learned about loss to follow-up patients' treatment adherence plays an important role. Additionally, drug-drug interactions should be avoided. For example, antiretroviral treatment agents among HIV patients, like efavirenz, can act as CYP3A4 inducers and therefore lead to decreased levels of beta-caline, so subtherapeutic levels. Usually, beta-caline is given for 6 months, but there have been a lot of successful reports of prolonged beta-caline treatment. And for example, in the BPAL regimen, it's given for up to 9 months. However, if you have a patient that does not convert after the intensive phase, you don't want to give beta-caline for too long, because beta-caline would then not be well protected and you risk acquired beta-caline resistance. Also very important is the regimen composition, to focus not only on the number of likely effective drugs, but especially on the drug activities. And because of the delayed activity onset, you want companion drugs, or at least one companion drug, with a high and early bactericidal activity. Even though the WHO has phased out the injectable agents, there have been very successful reports, for example, from NIGA, where second-line injectable drugs were used with the tight monitoring for adverse events like hearing loss. And once there were signs of a beginning hearing loss, the second-line injectable agents were switched to linezolid with very, very good results. Also, there have been thoughts to maybe only apply the aminoglycosides in the first 1 or 2 weeks during beta-caline treatment, where the delayed activity onset takes place. The concept of core and companion drugs introduced by Armand van Deurne says that core drugs should have both high bactericidal and sterilizing activity, whereas companion drugs protect these core drugs and can have all different kinds of activities. To compose a regimen, you should choose one core drug and add at least one drug with high early bactericidal activity to protect it. Then you should add another companion drug with bactericidal activity, and additionally add 2 drugs with sterilizing activity, usually pyrazinamide or clofazimine. He also provided a table or an overview of anti-TB drugs and their characteristics, like the bactericidal activity, grouped them in low, moderate, and high, and their sterilizing activity. And at the moment, for drug-resistant TB, we only have the fluoroquinolones and bedaquiline as core drugs. Some drugs are missing, like pretomanid, and maybe this will become another core drug, but the future has to show if that might work. So, last but not least, there are also some TB experts who are considering that the WHO should rethink their recommendations and maybe keep bedaquiline only for third-line treatment. So meaning that not all patients should receive it, but for example, patients with just rifampicin or multi-drug resistance without additional fluoroquinolone resistance might be better off with the fluoroquinolone-based regimen, and that bedaquiline should rather be saved for more extensive resistance patterns. But there are good arguments for both sides. I'm not sure what some of you might think about this. These are my sources. And finally, thank you for your attention.
Thank you, Jahan. I see that some questions are emerging in the chat, or in the Q&A. So thank you for that. So we'll come to those questions immediately. Maybe first I would like to hear from you. We all remember, I think, or many of us remember the time the times that when patients had RRTB, that they had a very poor prognosis. Maybe only 50% of them would be cured, relapse-free. Nowadays, I think this has improved. So why are we so worried about a few percent of those patients with RRTB that have TB with additional resistance acquisition? Why are we so worried about what at the end is maybe only a small proportion of all those with RRTB?
Sabira Chassin gives a good example in her paper, and she refers to rifampicin. And in the beginning, after its introduction, there was only an incidence of about 0.1% of rifampicin resistance. But after 10 years, in some countries, these numbers did rise to between 2 and 15%, even in some countries. So we fear that this might happen with bedaquiline as well. And as you know, there is already increasing resistance to fluoroquinolones. And if we use our new and second core drug, the bedaquiline, this could be, could have very bad consequences for the future.
Thank you, Jahan. So now I'll go to some questions from the Q&A. Maybe a first one from, it's 2 questions that are more related to clarification, I think, or 3 even. The first one is, okay, which genotypic or phenotypic DST methods were mostly used in the studies that were retrieved for the meta-analysis?
For the phenotypic DST, it differed. Mostly it was a 7H11 agar, so a solid one, but some used the 7H9 one, which or the MGIT, so the liquid DST, and a few of them also used genotypic methods, mainly sequencing, and some used both, but the majority used phenotypic methods.
Thank you. Another question related to the diagnosis of acquired resistance is whether also heteroresistance thus with the presence of both wild type and mutant DNA with regards to resistance to bedaquiline, if this was also considered as resistance to bedaquiline, or if it even was reported as such by the studies?
Yeah, only a few studies did that. And we once a mutation came up for the genotypic ABR, even though it was just considered as heteroresistance, we counted it as genotypic ABR, because when we looked at the MIC levels, most of these patients did also develop phenotypic ABR during the course. But yeah, many studies did not specify heteroresistance itself, but a few, like 2-3 of them did.
Thank you. Another question with regards to acquired resistance, whether there was any report on the association between treatment interruptions and acquisition of resistance to bedaquiline.
So there, not as part of this review, but we know that there are some reports, study from South Africa, and also one of the co-authors did a study in Uzbekistan, I think, where they could see that a few of the lost to follow-up patients did develop acquired bedaquiline resistance several months after treatment stopped. So even after treatment interruptions, that can happen. Yeah.
So I'll go for another question with regards to clarification. Was there any report on cross-resistance between bedaquiline resistance and resistance to clofazimine?
Yes, a few studies assessed both, and usually when there was bedaquiline resistance with the RV0678 mutation, clofazimine resistance was present as well. Not in all cases, but mostly.
Was there any report on whether previous use of clofazimine indeed then later on resulted in also a high risk of bedaquiline resistance?
In the studies we included not, but there was one we couldn't include because it did meet an exclusion criterion. There were a few patients who had clofazimine use in the past, and then it could be seen at treatment start that they had a RV0678 mutation, and this did lead to increased MIC levels for bedaquiline, and either at the treatment start or later on they develop phenotypic acquired bedaquiline resistance, actually. So cross resistance did happen.
Okay, thank you. So now I would like to experiment a bit whether we can have also participants having their questions expressed in a live manner. So the next question would then be from Kin Zarli. He or she has a question that I did not fully understand. So if Kin could explain this live. If you are able to turn on your mic. And then later I will ask the same to Ellen Mitchell. She also has a very interesting and maybe complementary question too. So Ellen, you can try at the same time if it works. That would be nice. Then the one who is able to turn on the mic the earliest.
Okay. Okay, Tom, can you hear me?
Yes, please go ahead, Ellen.
So I would like to get more information on why you are advising on avoidance of bedaquiline usage longer than 6 months. I would like to clarify, for it is recommendations for every patient, or it is recommendations for the patients who are suspected failure of treatment?
So the question
yes.
is, if a patient has treatment failure, should we then indeed extend or not extend the use of bedaquiline? Is that correct?
Yeah.
Yeah, I would say not in general, but as you said, for the ones who fail to culture convert, because they are mostly bedaquiline is used for 6 months because the approval studies, it's approved for 6 months, and it's more like off-label use if you use it for a longer duration. But mostly it works well. If you give it longer, you have successful treatment outcomes. But if you have cases where you have a patient who fails to culture convert, and where you might even suspect a failing treatment, then you should be careful to give bedaquiline for a prolonged time, because the regimen might be compromised in itself. And maybe yet there's no resistance to bedaquiline. Some clinicians might consider, okay, I don't want to declare failure. I want to add maybe a few drugs to the regimen. But we have to consider that some of these drugs might not actually work well anymore, and Bedaquiline wouldn't be well protected. So personally, I would advise to rather declare failure and start to construct a new regimen. Hope that
that's a very important take-home message indeed. So thank you, Jan, for this answer. Ellen, sorry. So thank you, Kim, for your question. Ellen, if you manage, you're next.
Yes, thank you, Jahan, for this timely review. So given the long half-life of bedaquiline that you describe and the disproportionate risk of acquired drug resistance given loss to follow-up, I noticed that your recommendation is to provide support, treatment adherence support to patients. And of course, that's been recommended for decades. I'm wondering if you would go a step further and suggest that maybe different types of patient support, like conditional cash transfer, food security, housing security, nutritional, psychosocial support, whether we should start to think about those as like co-treatments for bedaquiline regimens and make them more of a prerequisite as opposed to a add-on, given the risks you describe?
I think that's an interesting question that might be difficult to answer. I might even say, should we consider to make it a prerequisite for all TB treatments? Because as we know, adherence is very important for the treatment itself. And I think it's always difficult to make things mandatory, because some people also think, okay, you should only give bedaquiline with mandatory drug susceptibility testing. But in some settings, this might not work. And there might be some patients who would never have the chance to receive a good drug like this if this would always be mandatory. I think that these interventions you suggest are very important, and every country should try to provide all of the patients with these support measures. But I guess it's always different to make things mandatory. But I would also be curious what you think about it.
Yes, Ellen, please go ahead.
Thank you very much for that nuanced answer. I think that reflects that you've thought a lot about this, the pros and cons of access versus quality of the care that we provide. I guess I agree with you.
Thank you. As I did not find any other question, maybe another question from my end, Jan. So did you find any report on what was done with those patients who had RTB, started a new regimen, including bedaquiline, and who have probably the new XDR-TB treatment, TB resistant to all core drugs and maybe even linezolid or not? But did you find any report on how such patients were treated?
Not as part of the studies, but from talking to other clinicians who have been in contact with patients who sometimes are defined as totally drug-resistant TB patient, even though the term is negotiable. Sometimes, or like often, clinicians try to go for salvage regimens to put in all kinds of drugs that are left, even some with resistance, but in a higher dose. And yeah, the success rates are very low. And also it's very hard for clinicians to consider palliative care in these cases, because sometimes you have to talk to patients and say, I don't have really any other options for you. And you might only suffer more if we try to give you more and more and toxic drugs and won't improve or won't cure your condition. So there's also the option, to decide together with the patient to refrain from further treatments.
Is there any experience in the audience with regards to the treatment of patients with the new XDR, let's say? TB resistant to rifampicin, fluoroquinolone, and bedaquiline.
So you mean if there are any reports? Actually, I can't remember a specific report yet.
But maybe among the
came-
audience, there are clinicians who are involved in TB care in their country. Any experience? How do you address this? I guess most of you, or some of you, are working in countries where bedaquiline is also used now in most patients with RTB. So I guess some of those patients have these poor treatment outcomes described here. So what is done for those patients? Maybe while you may still reflect about providing your experience, maybe still another question to Jan. So it's not so easy. I hear, okay. So sorry, I may have issues with pronouncing well your name. Aigmul, if you wish, you can share your experience live. You can, please go ahead. Does it work? Sorry, it's not possible. All right. So thank you anyhow for trying. So Parvati says she can't unmute either, but she has a good experience with successful outcome. That's interesting to hear, because without core drug, we'll be interested in how to treat such patients. We know that pretamid is now around, but it's currently only recommended in combination with bedaquiline. So patients previously exposed to bedaquiline or even with resistance to bedaquiline actually would not be eligible for this BPAL regimen. And we see that Aigmul also tried to treat such patients, but then without success. So I think we'll have to learn all together. Yes.
I can speak now. So,
okay, please go ahead.
I've had a couple of patients, like maybe 3 patients that I can think of, one in each project. Usually, as Jahan says, you just give whatever drugs seem to be susceptible. We add delaminid and imipenem to the regimens, and then whatever else is remaining. And also high-dose fluoroquinolones are coming up more and more, and with fairly successful outcomes. I've also seen 3 patients from Uzbekistan who were bedaquiline resistant. I follow them off and on, and as of now, they're culture converted, but they still don't have an outcome. So we're not sure how it's going to end up.
Very interesting. I think it's important to document very well, because I think there's no evidence out there on how to manage such patients. So if I understand you well, you use some drugs for which we hope that we get some bactericidal activity, no true core drug, but then you hope to combine enough drugs that actually this core drug role is kind of fulfilled by all those companion drugs together.
Yeah.
Then I see that Christelle has had some experience. Please, Christelle, unmute and tell us how it went.
Thank you, Jan, for your presentation. So what we do here is that we do an individualized regimen for patients. When you have a patient who failed to the bedaquiline, we don't have much, but we have a committee that sits and discuss based on the results, the resistance profile of the patients, and then we do combine the remaining drugs available in the country to build a regimen for the patient. Usually is what we have, is what we are left with, and then we observe the patient, we monitor him or her to see the outcome, and we give supportive management as well. But there's no one rule, it's based on the resistance profile and then what is available in the country. Thank you.
Thank you. I see that Elizabeth also informs us that she has a patient who could maybe fit this definition of XDR-TB, and she's still waiting for expert advice. So maybe Elizabeth, I recommend you to document your patient and put it in our peer group, and we can all together maybe come up with some advice on how to advance with that patient. I think there's another question from Kim. Yes, is that Elizabeth?
Yes. So most definitely, I think I have shared that patient, and when the results came, he's resistant to everything. So yeah, documentation and then way forward as to what to do for that patient.
Then there's a question from Kim. So the question is, okay, after previous use of bedaquiline, and there was some interruption, maybe due to adverse events or whatsoever, of the regimen, maybe not because of acquired resistance to that drug, I guess. What about reintroducing the drug, and how should we do that? Jan, maybe I give the floor first to you. Any ideas on what you would recommend?
I would have to check with the recommendations from Janssen Pharmaceuticals, but I would think that that you would restart, like usually when you start bedaquiline in the first 2 weeks, you give it daily in a different dose, and then in the 3rd week, you start to give it 3 times a week. So I would just restart the process, but always consider, if you had a failing regimen before, that you cannot or you should not consider bedaquiline as a core drug anymore, because it might be compromised. So you might have to build a stronger regimen.
Thank you, Jahan. I've not that much to ask. I just was asked recently to review another review on bedaquiline resistance. And actually there they also had the issue of tail protection. So if you would have a patient who's on a bedaquiline-based regimen, and that you then consider, okay, we have to stop this regimen, for instance, for adverse events, and the patient is very sick, to consider how that maybe you would like to still extend the use of some drugs to protect the remaining bedaquiline that is circulating. However, there is no evidence on how to do that, I think. So I think this question, it's a good one. It's not easy to answer, and I think I would go in the flow that as mentioned by Jahan. Any other issue or question from the audience with regards to how to deal with patients previously exposed to bedaquiline, or even who had a treatment failure during bedaquiline-based treatment?
Jahan, this is Bouke. And Jahan, congratulations on your really nice presentation. Regarding the restart of bedaquiline, I saw in someone's summary of the Union conference that there was a clear table that if you, they related the duration of interruption of bedaquiline with advice on how to reload and resume. I can find out if that is available, that table for dissemination in the Alumni platform. And then I was just trying to find if Farzana Ismail had published the data yet on surveillance of bedaquiline resistance in South Africa, which is not yet in PubMed, but some of you may have attended the Resist-TB seminar in January, where she was showing data that very much correspond to what you are presenting, with about 2.3% acquired bedaquiline resistance in patients who started with a sensitive isolate and had completed bedaquiline treatment, but were culture positive. So that is indeed worrisome. And with regards to the question of what do you then do, what Francesca Conradi, who was one of the moderators, said was that clinicians receiving those results, like your patient has a high MIC to bedaquiline, they were not really sure what to do, and they were saying, yeah, we have no other options, we continue. So I think indeed the rate of acquired drug resistance with mutations in the target ATPE is still very minimal. I think there's maybe a handful of isolates worldwide that have acquired ATPE mutations, which confer high-level bedaquiline resistance. But RV0678 efflux pump mutations, which are the bulk of bedaquiline resistance, tend to not give super high resistance, but we don't yet know what it means clinically. So indeed, I think we urgently need solutions to how do we interpret those mutations so that we can work towards molecular diagnostic tests for bedaquiline resistance, and rather than phenotypic testing. And we need to know what is the clinical breakpoint. Is there still any point in using bedaquiline when there is resistance? So more questions, but congratulations on your very nice presentation.
Thank you, Bouke, for the contributions and for the nice words. Maybe a final question to Jahan, then maybe less technical than the previous question. So you did a systematic review. You did that by yourself without a second review. And our second and even a third review is doing the same, is kind of validating your work to get your work publishable. But how did you experience doing systematic review for a thesis? Any recommendations, any pitfalls? And maybe interesting for the others to hear about that.
Yeah, it was a learning process. And I worked mostly with Excel and was a lot of typing and yeah, stupid work. So I know that there are certain tools out there, some even as freeware, that can help you to make this process much easier. And I think if I would do it a second time, I would rather rely on yeah, certain software to save some time. And it's also always very good to have well-defined inclusion and exclusion criteria. The stricter you are with them, the more easy it is for you to exclude records that might not be that interesting, and might save a lot of time for you. So these would be the two things.
Thank you, Jahan. Thank you. Any follow-up question from any person in the audience who is contemplating about starting a review or is doing a review? Or if not, Charlotte, I think I give the floor back to you, and I thank Jahan for and all the participants for for a very nice presentation, and also for a very interactive debate.
Yeah, thanks everyone.
Also from my side, thank you very much to Jahan for sharing your insights and research findings. Also to Tom for the interactive moderation. Also to the audience for the interactive participation. Also to Yves for the technical support, always very precious. Thank you for completing the survey that will pop up, which allows us always to further improve the webinars. And also save the date for the upcoming 4th ITM alumni webinar in December with Hendrik Swanepoel. So looking forward to seeing you there, and stay tuned because more information will follow. Thank you very much to all, and looking forward to you again. Thanks. Bye-bye.